Hello, everybody, and welcome to Endoscopy Talks. I'm Christopher Chamness with Carl Stortz. Thank you for joining us on behalf of Colorado State University's new Translational Medicine Institute. Today, we are joined by Dr. Denis Verwilghen, Associate Professor of Equine Surgery and Head of the Camden Equine Center at the University of Sydney. Denis is originally from Belgium, where he started out as an equine practitioner after graduating from the University of Ghent. He then returned to academia to become a resident in equine surgery at the University of Liège, after which he passed the exam of the European College of Veterinary Surgeons to become board certified in 2010. He then went on to earn a PhD and then served as head of the equine surgery department at Uppsala University in Sweden, and then later associate professor at the University of Copenhagen. Today, Dr. Verwilghen will discuss the basics of oral endoscopy in horses.
Thank you for everybody for being here and showing your interest in equine oral endoscopy. And thank you, Christopher, to invite me for this and start Carl Stortz and the Translational Center in Colorado for supporting this talk and myself providing it to you. Although I use Stortz equipment on a daily basis, I have no ties to them. And I cannot declare any conflict of interest that would change my personal view on this subject. So I'd like to get cracking with my talk now, if that little Australian fly that is here in my office will actually let me, by starting with oral endoscopy. Why oral endoscopy? Why oroscopy as part of equine dentistry? Because I think we all know that equine dentistry is pretty much the art of waving a rasp in the dark cavity that is the horse's mouth, that a good grinder is key to a good tooth. And I'm just kidding, the smoother the merrier, or that is unfortunately how equine dentistry has been sold over the decades, and still many locations in the world would see it like that. And if that's the case, why do you need oral endoscopy? Is it just to see little friends that the horse might have into its oral cavity? Or may it actually be that equine dentistry is actually not about rasping teeth? Equine dentistry, at least the way I see it, is like any other part of the medical profession that we do. It's about diagnostics. That is the art that we as doctors are performing, is the art of diagnostics. And in particularly with the horse's teeth, it is about looking at preserving the horse's dental capital as much as possible. And if you look into an oral cavity like this, just with an open mouth, a gag, it might be difficult to see what is going on. This was a horse that, although for me it's very clear and I don't need an oroscope for that, seeing that this horse suffers from a sagittally fractured 109, that horse had been seen by several vets before, including my hospital interns that couldn't find what was going on. And that is generally because people do not put themselves in the right situation and use the right tools to actually make diagnostics possible in the horse's oral cavity. And there are several ways of doing. There's this very modern way, like you can see here on the picture, using the latest iPhone torch to look into the horse's mouth. It gives you a brilliant light, but it doesn't allow you to see anything in the end. You can add a mouth gag to that and a bit of a better light source that will allow you to see a little bit more. You can have a good light source and a whole set of pairs of eyes that look into the horse's mouth, and you may come up with a little bit more ability to diagnose things. The use of a mirror is definitely a plus, and if you don't have access to an oroscope, and I hope that after today, if you don't have any, you might consider investing in one. But the mirror can actually show you many things that the naked eye can't. But as far as I'm concerned, it is very much the horoscope that allows one to give or get the best diagnostic ability into this black box that is the horse's oral cavity. And there are many pathologies or many things that may be unclear with the naked eye or even with the mirror that actually become very clear with the horoscope. And from a little pilot study that unfortunately didn't run as it should be because it was impacted by the COVID situation, I ran with one of my students here the little study trying to explore the benefits of oral endoscopy to investigate dental pathology in horses' cheek teeth, where we compared just a visual exploration with a light source and a probe with the cadavers being gagged open, adding a mirror to that or an oroscope. And then eventually the cadaver heads were dissected and we looked at the pathologies in the most direct way, meaning looking at gross anomalies. And what we saw is that the horoscope does increase definitely the diagnostic accuracy of the procedure, but it's not necessarily leading to having more diagnostics. It can also be to have more precise diagnostics, things that might be missed by just visual exploration, like little fissures, or where we are in doubt if it is a fissure or not, with the mirror, become very clear once we start using the horoscope. So it's not only about the quantity, but the quality of the diagnostics that we could see made the horoscope made a difference. Horoscopy is also very useful to help you for extractions. As you know, the motto of dental extraction is detooth the whole tooth and nothing but the tooth, meaning detooth, you want to be sure that you identify the proper tooth that you want to extract. The whole tooth, you want to be sure that you remove the entire tooth when you extract, that you don't leave any pieces behind. And nothing but the tooth is that you do not damage any structures adjacent to the tooth, whether it is bone or other teeth in the venicity of the one that you're wanting to extract. And horoscopy will be an outstanding tool to aid you in actually achieving those three critical points of the tooth, the whole tooth, and nothing but the tooth. There's also extraction techniques like the minimal invasive transbuccal extraction, where horoscopy is a must. Performing this technique without horoscopy, I wouldn't even consider it. I'm sure some people do, but it is not such a difficult technique, but requires a kind of accuracy that can be achieved by being guided by endoscopy. Also, finding lost little fragments in non-healing alveoli, where you have certain bone sequesters or parts of teeth that are missing. Horoscopy has shown to really be a invaluable asset to be able to solve more complicated cases. As well, for me, in the management and follow-up of diastema treatments, particularly since those are often located in the more caudal aspects of the oral cavity, having a scope available to allow proper drilling out and cleaning of these diastema has shown very, very beneficial. And then in another scenario where we are trying to find out reasons for secondary sinusitis, the upper pictures there are from a case I've seen yesterday that was presented with suspicion of secondary sinusitis. Two vets had looked at the mouth previously and did not find anything. Oroscopy allowed a much closer look into the mouth and see that one of the pulp cavities in the 108 here is totally open and probes very deeply, which led us to the suspicion that this tooth was actually the cause of the problem. Same thing on the lower image, where you can see on the buccal side of that 109 that there is actually a part of the tooth missing that has chipped off. In at probing and palpation along that, there was a small fistulous tract that was at the origin of the sinusitis in this horse. But several previous investigations without oroscopy had not been able to actually show that. I'm sure that with a good mirror and a good light, there might have been a suspicion, or this could have been shown. But oroscopy makes it much faster and accurate. I do use oroscopy as well a lot in the management of oronasal or oral sinus fistulas, together with the minimal transbuccal access and techniques to curate those out and put in place some bridges. Where oroscopy then also becomes invaluable is in endodontic procedures and reconstructive procedures, where it is essential to be able to actually have a good view onto the occlusal surface of the teeth in order to perform the reconstructions. So I've been asked here is to insert a slide approximately a third into my talk to actually see if at this stage we were having any questions.
You're right, Denis. We don't have a lot, but we do have a couple. They're about scopes. One says, can I use an old 10 millimeter laparoscope? And what are your comments about scope safety in general, using these scopes in the horse's mouth?
Yeah, this is good question. What can we use? And actually the next part of my talk will be about what to use and what not to use. So maybe I'll answer that question at the end if it's still if I haven't answered it by the follow-up I have in the questions, if that's all right.
Of course. And can we use the scope to evaluate the sinus?
Yes, we can use a scope to evaluate the sinus. So sinoscopy is definitely something that we can do, but it's not the same procedure, and I would not use the same type of scope for doing that. So I'll come back to that. Remind me, Christopher, to put a little extra note at the end around that.
Sure. Okay, that's it for now, Denis.
So indeed, very, very good question there about what can or what should we use. And I don't know how familiar the whole audience is with different types of scopes, whether rigid scopes or flexible scopes. But basically, those are the two systems we have available: flexible scopes and rigid scopes. And so mostly people will ask me in the first place, can I use my flexible scope for doing oral endoscopy? And I'll say yes, but then I always think of my wife, which is a picture of Gabby here. doing some flexible endoscopy, and having this at the end with a chewed up gastroscope, because it got retroflexed into the oral cavity, not by doing an oroscopy, but whilst doing a gastroscopy, and the scope ending up into there. So it's not so handy to go and explain that to your boss, or if you're your own boss, to go and explain that to your banker and say you need new money because some horse has been chewing on my gastroscope because I used it for oral endoscopy. And despite or even not taking into account the danger for the scope of using it in the oral cavity, the flexible scope, like we have them, does actually not give you very good imaging and doesn't allow you to investigate the oral cavity very well. So it's dangerous and pretty much useless when you use that one. So are a lot of these models that you could buy in DIY stores for looking into drain pipes or at the bottom of cars or things like that have a flexible head. The image quality is generally very bad, and the flexibility of it and the tip, you want something that looks upwards, and those scopes look forward, so don't really allow you to do the job that you need. I'm sorry if I'm offending anyone by thinking people might be ignorant to the concept of endoscopy here, but I just found from several courses that I have been giving previously is that people at least need a little bit of a reminder of how those systems are set up and what you need in order to have the best outcome, and seeing what you need to see, because a scope is not just a scope. And for that, we need to remember that there are three different parts that, as far as I'm considered, are important to remember and understand in oral endoscopy. And that is, first of all, you need a lens, you need a camera, and you need a light cable. And lens and camera, light cable might all be incorporated in one. It could be separate pieces. But for the purpose of that talk and considering what I use three distinct elements, which is lens, light cable, light source, and camera that goes then to a processing unit and a screen. And if we look at the lens, remember that what you're doing is you're not trying to shoot very precisely. So a lens can have a field of view that is the way it is looking at, whether it is something looking very narrow or something very broad. And obviously, if you're trying to shoot a target, you're looking at having a lens that is very, very narrow in its field of view, because you want to increase precision as much as possible. When you're looking at something that is of diagnostic purpose, like we're looking in the oral cavity, you actually want the field of view that is larger, maybe not as large as possible, but relatively large, so you can get a good overview and you are able to really have your entire tooth on your picture. So that brings us to the angle of view of our lens, and endoscopes go with an angle of view of 0 up to 120. In general, that means that you would need a separate scope for a 0, 30, 45, 70, 90, and 120 angles. So if you want to cover all the angles, you're looking at having 6 scopes. There is a laparoscope called endochameleon that is one one structure or one scope as itself, and that has a little wheel that allows you to change the angle of view from 0 to 120 over all the other options in one go, which is something that is handy for laparoscopic procedure, but for which I haven't seen any major benefit for oroscopy. So those are the different options. And for those of you that do arthroscopy or laparoscopy, we are used to would be used to a 30-degree or a 0-degree angle if it was for laparoscopy. And we know that by the use of our 30-degree, we have pretty much the best ability to perform most of the arthroscopic procedures and laparoscopic procedures with that. The thing with oroscopy, and that might answer the question of somebody out there that said, can I use an old laparoscope? Yes, you can use an old laparoscope, but it is unlikely your laparoscope is going to come with a 70-degree. Either it's going to come with a 0-degree and then it's not going to be useful. Either it's going to come with a 30-degree and it's going to be useful. It's going to be better, much better than anything else. But it's not what you'll be looking at in the ideal world. People generally think that in the ideal world, because you are entering the mouth straight, but what you want to see is upwards or downwards, that actually a scope with a 90-degree angulation would be the most preferred one. But in fact, it's the 70-degree forward viewing scope that will provide you with the best image as the one that you can actually see on the screen here, because it does not only provide you in the 70-degree with what you see exactly on top of your lens, but also somehow forward viewing. So your three-dimensional vision and your ability, not only diagnostic, but treatment-wise, once you start adding a probe or you start adding instruments for extraction, etc., will provide you with a much greater versatility than any other angle that is there. And this is just a short video that will show you how you always see the tooth that you're aiming at, but also just a bit of the tooth that is caudal to that tooth, and allows you to have a much better spatial awareness in the oral cavity than with another type. The next part in our setup, apart from the lens, and maybe to add to the lens, is that from a working perspective, a lens that is around 40 centimeters of length is probably ideal. Anything shorter than that might be a little bit cumbersome, as is anything that is longer than 40-ish centimeters. Too short you will always have, even with a 30-centimeter scope, the ability to actually investigate the oral cavity. But if you start working with a scope and with an instrument inside, the whole setup of your camera and light cable, if the scope is too short, might obstruct your ability to actually work. If the scope becomes too long, then it starts to become heavy, and your leverage that you have on the scope hinders your ability to actually work as well. The second part of your construct would be your camera, and we'll talk a little bit about wireless cameras at the end of the talk. I think you can make the camera as crazy as you want in terms of the quality of the camera that you're looking at, whether it's a 1 chip or a 3 chip or whatever fancy thing that is available. But there is one very small thing that is the most important to remember, and that is down is down and up is up, or up is up and down is down. As you may know, on these cameras, there is buttons on top. And when the buttons are facing up, that means that whatever you see on the screen is also facing up. So with the buttons up, on your screen, what you see is the maxillary arcade on the upper part of your screen and the mandibular arcade on the lower part of your screen. If you turn your camera sideways or upside down, what you will have is that you will end up in a situation where your mandibular arcade shows on the top of your screen and the maxillary arcade on the bottom of your screen, right? And why is this important? Well, it's crucial because it allows you to keep the same anatomical orientation as what you have in the real life. And for just an investigation and just a view, that might not be so difficult. But if you also, if this is the scenario where you enter a probe or an instrument into the oral cavity, if your camera is in the proper orientation, that instrument will also enter that cavity in the same direction on your screen as it is when you enter it through the mouth. So if it comes from the right, it will show up on the right on the screen. If it comes from the left, it will show on the left. If you turn your camera upside down, then your instrument is going to come from the opposite direction, and it's going to be extremely confusing. And I see this over and over again, whether it's in oroscopy or whether it is in arthroscopy or laparoscopy. When I give courses or when I train my residents, I see that when people get lost, it is because they forget that the camera turns around the lens or the scope, and that changes the spatial orientation. So if you ever get lost in the oral cavity or anywhere else, look at your camera and make and ascertain yourself that the scope is, or the camera is up and down in the proper orientation. When you are in the oral cavity and you're looking at the maxillary arcade, so the upper arcade, then the mesial part or the front part of your tooth is going to be located on the top of your screen, and the caudal aspect of the tooth is going to be on the bottom part of your screen. When you are looking, so again, this is a maxillary arcade with mesial in the upper part of your screen and caudal in the lower part of your screen. When you are going to have to turn your scope around to look down instead of up to see the maxillary arcade, then what you will see is that that orientation will shift. Caudal then becomes the upper part of your screen, and mesial then becomes the lower part of your screen, if that is clear. And this is just because when you're looking with your 70-degree into the maxillary arcade, you are looking up, and you're looking with your camera there. Your camera stays in the same position, but your scope is going to turn around and is going to look down. So the actual orientation on your screen is going to inverse, right? But again, don't turn your camera with that. Otherwise, your you're going to get a mandibular image that is going to look as if it is a maxillary image. How to recognize teeth in the oral cavity on a screen? There is some little tricks there. I don't know if people see my mouse going over, but there is a little part of the tooth's design here of the enamel fold that you can see on the mandibular teeth, that looks like a butterfly, or here in Australia they say like a bull sack. Doesn't matter what you see in it, but when you see that, you know that you're pretty much looking at the medial or the mid part lingual aspect of the tooth, right? So that allows you to orient yourself lingually and know what is mesial and what is distal and buccal as well. There's a similar little thing to see on the maxillary teeth, where mesial, you can recognize on this tooth that mesial is on the upper part and palatal is on the right side. And why is that? Is that there is what we would call a cat's tongue, or a little invagination of cementum there in that enamel fold that orients itself in the distal palatal direction, and that is the same on all the maxillary cheek teeth, and allows you to know what is distal and what is palatal. So that allows you to identify your tooth location or direction, at least knowing which tooth is numbered. There, I guess you need to count the teeth as you go in. The 6 and the 11 are generally very easy to recognize, as is mostly the 9 as well. But that may need a little bit of a double check. Is there any other questions, Christopher, at this stage that we are?
Yes, we do have a couple. First one says, you spoke about angle and length. What about the diameter of the scope? What do you recommend?
The diameter, I would go about a 10 millimeter is I think, anything smaller would probably do the job. But from a safety perspective, I think the 10 millimeter would be, I personally haven't had any of my scopes crushed so far, but you know, maybe I haven't done enough fluoroscopies yet. It's just a matter of numbers and things like that. Anything smaller than a 10 millimeter, I think would just be a danger to the scope. Also, I would highly recommend to have a protection sleeve over it, and not just using the scope without its protection. If we're talking, the Storz has a, I used to have a boroscope from Storz, which was a 70 degree. That was before they had the dedicated boroscope. And the boroscope came with a small, tiny sleeve over it. But then the oroscope now has a much thicker sleeve. Particularly the one that has a flushing canal. I still don't find the flushing canal very useful because it doesn't really flush the lens, and it may be useful if you're trying to flush a cavity, but then your lens becomes, blood drips on your lens and so forth. But what it has is that the very end of that sleeve is it's a much thicker case, and that is generally where you're most at risk of damaging the scope. So there's the classic sleeve, protection sleeve, and then there is the flushing sleeve. And whereas I would not necessarily recommend the flushing sleeve for the flushing function, I definitely recommend the flushing sleeve for its increased protection of your scope. And you're talking, I don't know what it is in your country, but at the top of my head, a dedicated oroscope, you're talking around €2,500 or something around that price, I think. But it's definitely a piece of equipment worth protecting. Does that answer your question?
Absolutely, I think it does. What about fogging? Do you have a problem with fogging? And if so, what do you do to address that?
Yeah, fogging is a problem. Fogging is a problem. I generally I wipe it, so I have with my gloves, and it's having the scope a little bit in a warmer water bucket, like lukewarm water, and just then have it in the horse's, like just in the front of the horse's mouth for a couple of minutes. So it can acclimatize, so that the temperature difference, because it doesn't matter what you're going to wipe on your lens, if the temperature difference between a very cold scope and a very hot mouth, it's not going to work, whether you put whatever product on it or so. If it is persistent, I use a little bit of alcohol. I know some people use chlorhexidine, but I am definitely against that for purposes of resistance developments, as it's using a critical antiseptic for something where it has absolutely no use and the potential to actually create resistance in your environment. I think it is not okay from an antimicrobial stewardship perspective. That same problem doesn't really apply with alcohol, because the alcohol will not stay in the environment; it just evaporates, and so I would use that, and then my finger every now and then to just go over it. Yeah. Does that answer your question?
I believe so, and I've just got one more. This participant says, "Your images are great. Have you made a visual atlas of dental pathology?"
No, so far I have not made a dental atlas for an atlas for dental pathology. I'm gonna throw Storz under the bus here. I'm sorry, Christopher, because I've actually thought about it a lot, and although the telepack system I have is a fantastic system, if I put in the effort of making a visual atlas, I need a system that is a high definition quality system, and I don't have that. And I've tried to get Storz to lend me one for many years, and it has never really happened. So there's a thing on your to-do list, Christopher. By the end of this talk, make sure that he gets a high definition system for a while, so we can make a dental atlas. But I'd be happy to do that.
Okay, that's it. These questions are now over. Thank you.
Again, to finish up about the lens, we've talked about the viewing angle, and people that do arthroscopy, laparoscopy will know that you can use the angle of your scope actually to increase your visibility. If you are used to an arthroscope or a laparoscope where actually the actual light entrance in the scope is fixed. If you're using borescopes, which are industrial scopes, or the Storz oroscope, you will see that the light entrance actually flicks around on its own around the scope. So you really need to turn that scope around in a different fashion. If you're using an old laparoscope or anything else, then you will have the same you will encounter the same flexibility as you have with an arthroscope, but it's just a slightly different way of turning the arthroscope than it is to turning the oroscope. And this is a bit of a view. As you see now, we're looking upside. If I turn the entire camera, this is what I'm going to get. if I am just turning the scope, this is when I'm sorry. In the beginning of my video, I'm gonna go back. So this is when I'm just turning the scope, right? And you see that I don't really lose my orientation. Up remains up and down remains down. This is just by changing the angle of my scope. Here, what I'm having here is that this is turning the entire structure, gives you an image like that where your orientation doesn't stay the same. So in this picture, what has happened is that camera and lens have been turned sideways, and so the whole image gets distorted, right? You can see what you can see, but if you're using instrumentation to come in the mount, this is going to become very confusing and very it's not going to be handy. Whereas in this scenario, in the beginning of this, you see that the orientation remains the same because my camera is still up, up, down, down. So my screen is the same. And the only thing that is moving is my field of view, is my scope in the beginning. One very important thing, probably one of the things that is mostly overlooked in oroscopy, is the importance of the light source. Again, those of you that are familiar with arthroscopy or laparoscopy or just flexible endoscopy, you will know that light is important. And in the other scenarios, in a joint, in any synovial cavity, or in an abdomen, you have a pretty or a relatively closed environment. It can be big in laparoscopy if you do it in a horse or in a cow or so forth, but it is closed. It's a fully closed environment. So there is not a lot of light loss. Whereas in oral endoscopy, you're looking at a dark cavity, but the front of it is open to the outside. So there is inherently a lot of loss of light. So you need a light source that is very potent. And that could be the light source you have from your system. One little note there is, remember that if you still have a halogen light source, they run by hours, right? So your bulbs cost a lot of money, and having your light source staying on when it is not needed is is kind of killing your light source more quickly than necessary. If you're losing LED lights, in general, there's 30,000 hours of light available in those. So it's going to be a lot of procedures before you run out of that. But with halogen lights, it is much less than that. It's about a tenth of it. So it's very likely you're going to run out if you don't spare your light bulbs properly. But that aside, the other thing that absorbs light source or light in the mouth or anywhere else is blood. So blood will absorb your light a lot. And that means that for me, at least, I will always supplement my light source from my oroscope with an additional light source that I attach to my mouth gag. I use these. It's a Belgian-made light source that's called Mitch light or Mish light. That is very thin and is a very, very heavy light that supplements the oroscopy lights, but maybe allows me to get better pictures as well, because there is enough light in there. Then a little trick as well for those that are investing in a system and don't have any. When you buy your light cable, there is several types of light sources, but I am using a light cable, and I like to have this little 90-degree angled light cable because it makes the whole construct of lens, light cable, and camera a little bit less bulky, and I can more easily put a rectal sleeve over the construct as well, so to protect my camera from any dirt over it. Have a proper setup, I think, is crucial. It's crucial for any type of scoping. It does really not work if your screen is looking the other direction than your horse or your joint. If you have to operate like this or manipulate like that, it is really not going to work. So make sure that everything you have is in line and that it is at a proper height. Arthroscopy or oroscopy, I think, works best on a saddle chair, on a dental saddle chair, not one that is very low to the ground, but one on which you can kind of sit and stand at the same time. That gives you the best posture to actually do your job and avoids a lot of fatigue. You can always have a second screen somewhere for your clients to see, which is generally good. That there is a bigger screen in the room to which your main screen is attached, so people can see the same thing as what you see. Here in Australia, at least, there are nice systems as this PortaSafe system that allow to do dentistry in the field or other procedures in a very safe environment in these stocks, and with which we've also done oroscopy in that, and in a very nice setup. Then in terms of material, about what I know, and as I said, I have no ties with Storz other than the fact that I'm giving this talk, or that I use their material clinically or at other talks, just as I use others' material. But I can just share what my experience has been with different equipment. There are, I think, maybe better full clinical systems available maybe than Storz has, or similar. But when it comes to something that is portable and useful for dentistry and very versatile, I think the Telepack that is available just beats everything else in terms of quality and versatility, and versatility in its ability to not only do oroscopy, but also be used for arthroscopy, laparoscopy, and flexible endoscopy, whether it's small or large animals, and large being equine or bovine, or I think you have a very, very mobile system there. That's maybe a little bit more expensive than other systems, like the dental stick there from Dr. Fritz that is available. I find it a very expensive system for what it is, because it only does one thing. You can only use it for oroscopy. You can't use it for anything else, and it is a wireless system. And I have an issue with wireless systems in the sense that so far there's still a lagging time. Whether it is with this dental stick or with the Firefly camera, where the lagging time between what the camera captures and what comes on your screen, it's a fraction and a fraction of a second. And it is very okay if you are doing investigatory work. If you're just looking in a cavity and just looking in the mouth, that's fine. But as soon as you start adding an instrument to that, whether it's a probe or if you do minimal invasive extractions, there is a short delay between what you see on your screen and you entering your instrument entering in the field of vision, and what's seen on the screen is not concordant exactly at the same time. And that can be very, very frustrating. because you keep on moving your hand and you keep on going, and it makes the task so much more difficult. So it's good for beginning, but it's definitely not to be recommended if you start doing things a bit more interventional. I've seen those on websites or also on the store stand booth at a certain stage with our certain adapters to put on an iPhone. I thought it was very cool and very useful till I then indeed thought of, say, if you can't see the screen because the screen and the camera scope are aligned and you're looking into the horse's mouth this way, and then if you want to then see your screen, you need to bend down because your horse is not straight in front of you. So unless there is a system that allows to bend the iPhone screen, it is not really doing the job. From a very practical perspective, I have a system in how I use the oroscope, which is that I start always by taking an overview image, like you can see that the big image on the left side of the screen that provides me with a general overview of the oral cavity, just as if I was looking with my eyes into it. I think that on my screen, it gives me an even better idea of the symmetry of the mandibular and maxillary arcades and whether there is any inclination in the wear or not. So it gives me a nice overview. It's always the first view that I take before I go and go from arcade number 100, 200, 300, 400, and I photograph every single tooth, 106, 107, 108, etc., etc. So I can actually, reconstruct the entire oral arcade with the images that I take. And this first picture, how am I taking it? Like you can see it here on the screen. I have the camera in biggest out, so in the biggest field of view. And I have the camera up towards me. Up is up and down is down, as you can see on the right lower picture. And then the oroscope is directed in the center of the oral cavity in pretty much a vertical way or a little bit angled, and that is what this image, how this image can be constructed. Otherwise, how do I obtain these images from the arcades? It's also about using your oroscope as a billiard stick and having your hand, your scope in between your fingers to actually guide it progressively into the oral cavity, and the rest is practice and practice and practice, and making sure that if you don't see what you think you should be seeing, is to look at your camera and assure yourself that up is up and down is down. Otherwise, you're going to be very, very confused. So remember, there's more things that you can do. Oh yeah, I needed to answer that question, sorry. Can you use this for synoscopy? Yes, you can use your light source, your camera, and your processor for it. But the 70-degree oroscope is definitely not a valuable tool for equine synoscopy. I would most prefer a 30-degree 4 or 5 millimeter arthroscope, or a 3.5 millimeter arthroscope, or even smaller, to do the synoscopies. That will give you a much better versatility and a much better view. Is it alone that the oroscope is about 40 centimeters in length, and that holding it through sinusotomy hole, trephination hole, becomes really dangerous because of the leverage and the weight of the equipment. So not handy. And remember, there's also other fun things that you can do with scoping, like abomesopexy, and do other type of fun stuff. So that was it for me now. Be happy to take on any other questions if there are any.
Yes, there definitely are, Denis. One of those questions is, I see you use a sleeve over the camera. Why? What is that needed for?
So indeed, you will see here that I have a sleeve over the camera. It's to protect my camera. So there's a lot of, there can be saliva and stuff like that dripping down along the shaft here. And then that gets over your lens and over your camera, and it just protects your camera and increases its longevity of life, and working a bit cleaner as well.
Mm-hmm. And last question here. Can you share with us one of your biggest aha moments and what that was, what you saw, what you learned in doing oroscopy?
Oh, I think the whole horoscopy has been a aha moment in itself. I think that there is no way I would go back in doing dentistry without horoscopy. As I said, there's a big paradigm shift in dentistry, is that dentistry used to be, or is probably still regarded by a lot of people as rasping teeth. And it's not about that. It's about investigation. It's making a diagnosis of dental pathology, and whether that leads to rasping or leads to something else, that's another story. But rasping is a treatment. It's not something. You don't just go out and treat horses. You go out and diagnose horses, and then set up a treatment plan and a prognosis that goes with it. And that we end up we have discovered so many more pathologies and their significance ever since we start scoping mouths. So yes, that's been my big aha revelation, is that there's so much more in that oral cavity than there was seen before, and that can be done.
Great. I do have a couple more questions now that just came in. Do you ever use the scope with the mouth closed to see occlusion?
No, not with the mouth closed or fully closed, but I do look into the mouth sideways as well. I'm sorry, the pictures that I've shown only show the occlusal surface, but I do also use or also take side views inside the mouth. Maybe I had some. Let me try and see if I had any. No, there's none there, but I would use side views from where I'm in the oral cavity. I think this one would be showing that somehow what you can achieve, and where you can see the side, and you can often see whether you have any excess transverse ridges or certain waves or occlusion or malocclusions that are in that direction. So yes, that can be useful.
Okay. And last question. Do you have any tips for getting a good view of the mandibular teeth? I have trouble with the tongue.
Yeah, the tongue is an issue. If I have procedures that are a bit longer or where the tongue can be a problem, not standardly for routine investigation, but I tend to give my horses a bit of diazepam, and so they stop trying to French kiss you when they have diazepam on board. But otherwise, it's a matter of getting your hands and getting your scope in between your hand and going and advancing. So you actually push the tongue a little bit to the side as well whilst you are at it. So it's using a combination of your scope and your hand into the oral cavity to allow to get a better image. And if they're still annoying you, diazepam is the way to go.
Okay. Fantastic. Thank you very much, Denis, for this actually really enlightening new presentation. Once again, I'd like to thank all of you in the audience for joining us. This was our last talk for 2020. We will now be taking a few weeks off for the holidays, returning on the 13th of January. So be sure to check out our new schedule after the new year to see what exciting topics and speakers we have lined up. And remember, any past talks can be viewed free online at endoscopytalks.com. I'd like to wish you all a peaceful and happy holiday season and new year, and of course, the best of health during these challenging times. We look forward to seeing you again in January.